And are there any questions on any of that? I'm sure some of these issues will recur in the rest of the programme. Thank you, Francis. Thank you. With that, we move on to the next phase of the programme, and I'd like to invite the panel members, please, to join the chairs. I shall vacate here, and I will now pass the microphone, in fact, to the moderator of this, which is going to be Tamsin Rose. Tamsin, thank you for joining us.
Thank you very much. Panellists, please come to join us. So we've just had a very valuable feedback from what was, I'm sure, very rich conversations in each of the workshops. And my task now is to see how we can pick up some of the strands, the recommendations from those different workshops and explore them with our panel, who are a number of distinguished people representing a range of stakeholders, just to look forward to where we are next in the next mandate, the next research programme, and where the EU could provide added value. So let me just start by introducing my panel in case you are unfamiliar with any of the faces. We have Cornelis Schmaltz from the European Commission, Bonnie Wolf-Bonisch from Science Europe, Pierre Moulin from the Innovative Medicines Initiative. We have Valentina Stramiello from the European Patients Forum, and of course the president of EULAR, a well-known face for all of you, Professor Johannes Biesma. So when I was looking at the slides that came from all those different workshops, it struck me a number of different things. And perhaps we'll jump straight in on the one that I think came across many of the workshops, the importance of interdisciplinary and innovative approaches to science. And maybe let me start by coming to you, Bonnie, from Science Europe, because in some context, we say the future of medicine and health is personalised. It's more and more specific. And yet we've also had a plea from this workshop about the importance of interdisciplinary, bringing in new partners, the unexpected partners. What's the view of Science Europe in looking forward for the next research programme? What's the value and the importance of bringing in the different disciplines together?
Yeah.
To speak and they will pick up.
You hear me? Okay.
Yes.
Yeah. Thank you very much. For me, interdisciplinarity is very important. At the moment, I'm responsible for a multidisciplinary scientific advisory committee from 30 scientists, and I think the future to collaborate to tackle the global challenge, we need to pool all the resources we have together, not only for the research community that they should work multidisciplinarity, but also with the industry partners and also patient groups or social partners to tackle the global challenge. And I think, or the recommendation would be also the future framework program, that in the current structure in the 3 pillars, beside the excellence of research, that we also try to better integrate the 3 pillars we have in order to tackle the challenges in the future.
Okay. Thank you. Let me turn to Cornelis. The European Commission is probably, as we speak, working on the early plans for the next research programme, and of course nobody knows yet what's going to be in the overall EU budget, let alone what proportion will go to research. But it seems clear that research takes a strategic role in the future European economy. So what can you tell us in terms of where research might lead us? In the past, we've had the big societal challenges, but society has moved on. The European Commission is looking at things like the future of work, the future of employment, and this has a very strong link to chronic disease, because people who experience chronic diseases, their lives are impacted, their ability to work, contribute and be part of the labour market. So to what extent will the successor to Horizon 2020 be looking at health in that broader aspect, the impact on the daily lives of people dealing with chronic disease?
I think that was several questions in one. I'll try to address several of them. So I think if you're looking, the closest indication that we have on the shape of the future, I'm sorry, apologies. The closest indication we have on the shape of the future framework program is the recommendations from the LAMI group. The Commission will respond to that, but will likely take these up. It is also, as I mentioned, the priorities of our current Commissioner, who of course will change in 2019, but will still, or is likely to change, could change, but will still shape certainly the early reflections. And I think there with openness, excellence, and impact, and that's the word, that's the answer to the last part of your questions. I think impact is indeed absolutely key and is the mantra, is what we need to demonstrate in order to prove our value for money. And I think impact in health research to a large extent is impact on patients' lives. And I think we have, I would argue, and we could go into details on that, that in Horizon 2020, or actually over the last 10 years, we have increasingly moved to topics that very closely take into account patient needs, that very closely look at the actual translation and at the implementation. That doesn't solve the problem that we do have a long lead time from research to final implementation, because we are not, I mean, there's a whole validation chain, regulatory issues is something that come after the successful research, but still I think we have, I would say, delivered, or at least on a good way to deliver on that impact for patients.
Thank you. And on the issue of patients, now let's turn to Valentina. This is something very close to your heart, and the central focus of the European Patients Forum is the role of patients in the research process. Several of the workshops talked about the need for meaningful engagement of patients, patient involvement right the way from an evaluation to implementation. What's the view of the EPF on what constitutes meaningful involvement in research?
Yeah, that's a big question. I would say for us, meaningful involvement in research means, as you said, involvement since really the beginning of the co-design of new projects and new research. This means also contribution to the definition of topics to be researched, because not always topics that researched are in line with the patient's needs. So we really would like to see patients' needs addressed in the researches. This is not always the issue. From a patient perspective, I would say, I mean, at least for EPF, but I think this applies to many patient organizations in this room, meaningful involvement is also about making sure that all patients across Europe have access to high-quality healthcare. This is not the case, as we all know, and that's why we strive for meaningful involvement of patients also from different contexts, from different nationality, different socioeconomic status, because only this way we can make sure that all perspectives are considered. Unfortunately, what often happens is that, I mean, and this is my experience in projects, is we are involved, but it looks like a not talking exercise most of the times, where they can say, okay, patients were consulted, patients were involved, but this is not the case. To be really involved, we need to make sure that the material we have access to is understandable for patient organizations in a way that we can transfer this information to our members, consult them, gather and collect this information and bring it back to the project team. I'm aware this means a lot of time, a lot of investment of time, and this means also redesigning the process. So sometimes, of course, this might mean a delay in the process. So that's why I always say we should really think ahead. If you want to involve patients, ask us at the beginning which is the right way to do it, instead of consulting us really when you're close to the final consultation and publication of your deliverable. This way it's not effective and it's not going to help patients at all. So I'm maybe saying what is not meaningful rather than what is meaningful. Maybe even the next framework program, we will be able to see what is meaningful, what is working, rather than what is not working. So I unfortunately, I have often had negative experiences. When I have the chance to collaborate with other stakeholders in the long run, I feel I tend to educate them the way they should involve patient organizations and patients. And in that case, I'm able to see some results. But when it comes to really spot collaborations, is not really useful and supportive, I would say.
So patient involvement at the early stage, including the definition of the research questions, rather than just a work package on patient involvement where patients sit in a silo, but across the whole process.
Exactly. This comes with a lot of challenges because, as I said, this means also providing material that is lay language rather than technical and scientific. This means also, as I said before, maybe delays or maybe dedicating a bit more of time to the delivery of some products and deliverables. I'm aware of that, but in the long run, this brings much better results, and we can really say that patients were involved in a meaningful way. I can bring an example with some IMI projects like Get Real, where EPF was not involved, but IAPO was. IAPO is the International Alliance for Patient Organizations. And yet the fact, I could see they were meaningfully involved, and I felt really comfortable reusing the material they had produced because that was meaningful patient involvement. And I'm not afraid of saying that in many other cases this doesn't apply.
Okay. Let me now turn to Pierre from the IMI, which when it was set up was groundbreaking and innovative, and we were already in unknown territory. And I'm looking at the title of today's session, Do We Need a Novel Approach? We heard in the workshop about public-private partnerships, about the importance of safeguarding the space for IMI. How do you see the IMI evolving and building in the next stage?
Thank you. So, I mean, I do think that we are in an evolving setting, whether we're talking about how we involve patients or engage with patients, how we involve other stakeholders. It's very clear we need to be more involved with the regulators, with the all-important health technology assessment, the groups, the health economists who can help us bridge this gap between the technology push, trying to push things out into use, and the pull, which has to be based on economic drivers from those who are paying for innovations, whether they be new medicines or diagnostics or whatever. And we're not very good, collectively, we're not very good at that, to be honest. We have not been able to convince the payers that innovation in general needs to be pulled. And I think the health economists at a research level really need to be brought in very early to deal with some of that. So I think the platform that IMI provides is that one where it is open-ended. And when we're talking about multidisciplinary research and development, it is going to get more and more multidisciplinary. And I don't think that's in contradiction with personalized medicine or more defined treatments for this and that, because the tools that one is going to need in order to define patient populations in a different way, those tools are going to be brought in by stakeholders that are maybe not at the table today, maybe not to the extent that they should be. And I think this is what we're going to see going down the line.
Okay, thank you. Let me turn to Professor Bismar. One of the workshops said there needs to be much greater connection between researchers and clinicians, and obviously by extension bringing patients in at a much earlier stage. Within EULAR, how do you make those connections between the people who are doing research and the people who are the clinicians who are actually delivering the care and testing it out? How do you make those connections work better?
Well, that's quite an interesting question. What we normally see is that we stimulate basic researchers, which you call the scientists probably, to be aware of the clinical parts, but also having the clinicians being aware of the basic science part. So we stimulate the communication between those two groups. And quite often we see that most of the groups are now led by physicians. That means they have taken on the duty to make sure that those scientists they involve in the research are educated and stimulated to see about the patient problems, the other problems you have as a physician. So it's an interaction. And it's very difficult to really stimulate that from as an EULAR organization. But if you are able to show examples that have proven the efficacy of this combination, then that will work. So we don't have a formal process in place, but for every application we receive, we're looking at this kind of aspects as much as we're looking at the aspects of involving health professionals, involving patients, and also looking at cultural differences as have been discussed before. So it's quite a complicated process, but these are important items to look for.
Okay, thank you. Again, picking up on things from the workshop, maybe I'll come back to you, Cornelis. The success rates. Horizon 2020 was notoriously hard to get funding out of, and some of our workshops said we need to increase the success rate to motivate people and keep people engaged, and also the number of stage ones that go through to stage 2. How is the Commission looking at that aspect? Do you see it actually as a good sign that there's a lot of competition, or do you recognise there's a trade-off between keeping people motivated and engaged and the money that's available?
I think it clearly is a trade-off. I mean, we are worried that we are not getting the best applications because people are not willing to invest the money for that small chance. So it is a concern. On the other hand, I've pointed to the difference in which ERC and collaborative research are often treated, and I don't think that is fair. So it can't be that in one program it's excellent and in the other one it's bad or something. So I think, I mean, we are in the dilemma there where there is no magic bullet to fix this. I mean, to me, as far as I can see, I'm open to other suggestions, but the 3 solutions are increased budget, narrow topics, and 2-stage calls. And we are willing to consider all of these. There are counter-arguments for each of these, especially the narrow scope is difficult because that poses the question of going back to the very disciplinary approaches. It gets rid of some of the interdisciplinarity and the innovation. So those are the tools that we have. I think you mentioned a specific issue. We have delivered on the flexible threshold. We are now very close to actually in the second stage, so for the 2-stage calls, in the second stage, we do guarantee that very close to 1/3 of the applications are funded. So that, I think, is a reasonable number. But other than that, we can't multiply the money or tell people not to apply. So I'm open to further suggestions. But we clearly see the problem, yes. I mean, I think. But also to mention that I don't know the very latest figure for 2017, but clearly success rates in 2016 were better than in 2014 and 15. We were actually at least close to or even slightly above 10%. Where previously we were below. So I don't have the figures for 2017, but there was a slight upward trend for the 2016 call.
So some encouragement for the people interested in applying?
Unless we are already seeing that drop of the best who don't come to us anymore. So that's, of course, also a concern. But.
Okay, let me ask the panel to pick up on an issue that was put on one of the results of the workshop, the importance of supporting research in prediction, prevention, and early intervention. Now, specifically looking at the issue of chronic disease, obviously prevention is going to be key, but health systems are notoriously bad at actually investing in prevention. So what's the role for the EU and at European level to try and support this shift to better prediction, prevention, and early intervention? Does anyone on the panel want to choose that one?
I'm delighted to take a brief start on that because that is actually very, very important to us. And when we talk about personalized medicine as really the key theme of our last calls and also of the coming call, and very likely we will continue this theme in FP9, then we are very much focused not only on personalized treatments, but also on personalized prevention. And I think that is going to be stronger and stronger because that is also eventually the way to counter this argument that you now hear occasionally that personalized medicine is medicine for the rich. No, it's not. It needs to be compatible with sustainable health systems, and one way to do that is to emphasize the prevention aspect. So I think it is very important to us.
Okay, thank you. Pierre?
Thank you. So, well, I think it's obviously really important. So I'll give you one example, a concrete example in Alzheimer's disease, because this is one where, as you may know, a dozen pharmaceutical companies were all in competition with each other for many years, probably spent over 8 billion euro trying to develop something for Alzheimer's disease, but was going into a population with, more or less terminal dementia. And so incredibly difficult to have any impact on the disease at that stage. So we have to find a way, and I'm not saying it's easy, we have to find a way of allowing ourselves to come in earlier in that disease, so that we can actually have some early intervention strategies, whether they be overall management or nutritional or medicinal or whatever, pharmacological or whatever. We have to find a way of doing that. So now those same companies have joined forces, are now sharing a lot of their data, a lot of their clinical data through IMI initiatives. So I think we have 250 million euro invested in Alzheimer's disease and 9 or 10 projects. And one of those, it's called EPAD, is actually constructing a group of people, 6,000 people, who are or may be susceptible to Alzheimer dementia, in order for interventions to be stratified and then to be brought on board, once again, pharmacological or not. And I think this is a very new way, very innovative way of changing the way we do things. Now, of course, that has huge ethical issues. Patients really need to be involved right from the beginning, but they also need to be allowed to be part of the risk-benefit discussion. So I'm potentially an Alzheimer patient. Who is deciding for me whether I should be in an interventional trial or not? Is it just I'm going to listen to my doctor? I'm going to listen to a professor of neurodegeneration from some university? I'm going to listen to a pharmaceutical company? I'm going to listen to a regulator? Or am I going to have a discussion at an equal level with those people, and we will decide together? And so this is the kind of thing. And I think for those discussions, talking about multidisciplinarity, back to this thing, for those kind of discussions, and I'm talking about Alzheimer's, but we can talk about many other chronic diseases, right? For those kind of discussions, I think we need to bring in a lot more of the social sciences, of the humanities, into these discussions, because these are not binary discussions that we can have.
Bonnie, I can see, I'll come to you in a minute, Valentina, but Bonnie, I can see you nodding to this question of openness to different disciplines, because it's not a transactional process. It involves culture, anthropology, societal norms, etc., bioethics.
I know that because when you said we have to involve scientists from social science and humanities, is absolutely crucial, especially in the discussion of ethical issues. My point, actually, I want to make was a bit different, and it relates to the fact that we're talking here about a paradigm shift in biomedical research, and it's not business as usual, so it's more about research agenda setting. And I was wondering if calls, especially in personal medicine, are sufficient. So there have certainly been some calls and pilots on that, but I was wondering if transnational instruments like ERANET or joint programming would be helpful to really look beyond these different research disciplines and to find out what is actually common goals or commonalities and cluster this interest. So it relates a bit to what has been said this morning from the representative of the World Health Organization, to be more strategic alliance and in order to boost this whole field and to move forward.
Okay, thank you. Valentina, you want to pick up, I'm sure, on some of these patient involvement roles.
Especially, yeah, my point would be rather about prevention. I mean, I'm aware the topic is addressed at European level, and there are joint actions like CRODIS and then now CRODIS Plus that are addressing this issue and trying to uptake good practices at national level. So we cannot say there's nothing over there. The problem in my perspective, and I must say it's not, EPF is not really focusing on prevention, but I would say that prevention needs to be tackled from an intersectorial perspective. So we cannot talk about prevention putting the burden on patients and citizens' shoulders without addressing it also from an agro-food industrial point of view, without addressing the topic of pollution. It's a bit misleading in my perspective to look at it as an individual issue. Rather, it's a societal issue that should include, as I said, agro-industry and as well as pollution, air pollution, and pollution in general. But I don't see it, and I'm surprised why there's no discussion on this issue.
Okay. Professor Bismar, you want to add
Yes,
to
I would
that?
like to add a little bit to that, because we had in workshop number 1, we had a very good discussion also about prevention. Prevention is very important, and we had nice presentations this morning also leading the way there. But we have what you might call low-hanging fruit. So we all know that obesity and smoking is giving a lot of health problems, but we are unable to stop smoking, we are unable to get people obese. So research in the area of implementation of what we find is very important.
Yeah.
And I think we should consider these items as well when we are thinking in the future.
Okay. Let me pick up again on something that came out of the workshops, which was this issue about the need for regulation for data sharing. Pierre, you mentioned that in Alzheimer's you had all these companies competing, and this isn't necessarily moving the field forward. Several of the workshops talked about the need for open data, shared data, there is greater research results being accessible to people. What do you feel, panel, about, is this something where we need to regulate at EU or national level? Okay, Valentina, pick it up, and then I'm sure Bonnie.
Yeah, this is a topic that we are addressing in an IMI project called Adapt Smart, where the issue of data protection, data reuse is discussed. And I must say, patients are in general very open to share data. The issue, I would say, rather ethical when it comes to reuse of data, because there might be misuse or unethical use of data after it has been used for the first purpose, which is maybe one researcher, if the data is still available, can use for other purposes that are beyond what the patients would expect. And so we need to, I think, regulate this issue of reuse. But from a patient perspective, there's no reluctance to make this data available.
Okay. So who else wants to come in on this?
I might just say
Yes.
a word or two on this, because we have a lot of projects on data, use of data, and trying to, at least to some degree, solve the issues. And the issues are, there are a multitude of issues at different levels. So there are inabilities for institutions to share data with each other. There are jurisdictional issues in terms of countries not being able to share data across borders, and so so I think so. If the question is what can we do, I think member states and the European Union should be working in some kind of synergy to really try, because I think the action cannot only be a European action. It has to be as well from the member states looking at their internal works and trying to work at how we can solve this issue, because it's a massive issue.
So, I mean, coming over to Cornelis, it's not as simple as saying if public money funded something, the research results should be available and the data should flow. There's more complexity to it.
I'll come to that in a second. Maybe first just one more comment on the question of data sharing and regulation, because I think at the moment we're not at a moment where we actually need more regulation, but we just have a new general data protection regulation. So I think the focus at the moment is on implementation and finding ways best practices and ways to use these legislative tools or the framework, and to make sure that we have a reasonable implementation in the member states of this regulation, and, as I said, to really use the tools. I don't think after these long years of negotiations of this tool that anybody is keen on reopening this at the moment. That was on the need for more regulation, which I think the moment is not the focus. On the issue of open data, I actually feel again that we are really, especially also in the Health Directorate, increasingly delivering on this. We were not part of the initial open research data pilot by default. We are, since 2017, part of this pilot, where data underlying publications should be shared in an appropriately pseudonymized or anonymized way in repositories or in any other way, shape, or form that the researchers determine. We require a data management plan that specifies that I think is actually formally that is only required in those that are in the open research data pilot, but I think that actually concerns absolutely every project needs to have a data management plan. And we are just now in the phase of concluding the first grant agreements from 2017, and we have a very good experience. There's a lot of reluctance or worry at the research community, also very much not only in industry but also in the academic research community when they hear open data, because they're concerned about IP protection and about personal data protection. But if we explain the issues that this is about data underlying publications, where usually you protect your IP before you publish something, and if we explain that we don't, of course, expect at some point raw individual patient data to be shared publicly, but in a appropriately aggregated and anonymized way, then we can usually lay these concerns to rest. And we might have 100% implementation rate of the open data research pilot, so possibly no opt-outs at all, or I mean, we can't force people, there is an opt-out possibility, but we put the bar quite high for the justification for the opt-out.
So that situation is evolving and may improve. Let me now turn to the floor. I have picked up some of the recommendations from your 4 workshops and I've put them to our panel. What else would you like to discuss with the panel? There's a whole range of issues that we could pick up. Is there any burning topic from the floor that you would like to pose? Yes, well, we have 2 hands up already. We'll start at the back and then we'll come forward.
Thank you, Professor Linson, from the MNRC. Just a few reactions, if I may. Yes, there's a mention of multidisciplinarity, but unfortunately, well, education is still very, very unidisciplinary. I mean, education has provided and is still providing, unfortunately, unidisciplinary excellence bathing in a sea of integrated interdisciplinary incompetence. I've been trying unsuccessfully to introduce neuroimmunoendocrinology as an advanced course in holistic medicine in medicine in medical schools. Nothing doing, just not possible. Education is still terribly fragmented. Pierre, sorry, regarding equal level discussions, this shall be possible sooner or later with customized interactive software, where patients shall be able to discuss theoretically, at least, their issues on an equal footing with physicians. Customized interactive software shall, in fact, also sooner or later replace university courses altogether. And finally, what do we mean by impact? What is excellence for? What kind of excellence is most needed for us human beings today? Well, here again, to achieve and sustain the citizens' well-being, quality of life, and world society. Thank you.
Okay, so the question of excellence I'm going to put on Bonnie's shoulders to answer. This issue about impact, perhaps, and the fact that we have people being trained in a single discipline. Professor Wiesma, I think I'm going to ask you to think about that and respond. Let's hear your question. Can we have the microphone to the front, please? Yeah.
Thank you very much. First of all, I would like to say thank you to EULAR for putting this very, very interesting day. My question may surprise some of you. I'd like to go back on the issue of prevention, which was discussed in the workshop number 1, in the context of chronic diseases, and also the recommendation of the Lamy report about impact and innovation. Now, very often when we talk about prevention, we don't make the distinction between primary prevention, secondary, and tertiary prevention. And if we look at the future of health research, and if we look at the fact that half of chronic diseases are entirely preventable, here I'm talking, and I'm going to ask you questions about primary prevention. What do we mean by primary prevention? We mean mainly changing the environment in which children grow up so that they don't develop cancer or COPD or heart diseases that are preventable. It means putting together the price up on unhealthy food, or what kind of messages could work so that price increases on tobacco or on unhealthy food could actually convince policymakers to put together policy interventions that work. And that kind of research is not conducted enough. So my question to you all is, the gentleman from the European Commission talked about impact on cities, on patients, and that is crucial, but that's secondary prevention. What we should also talk about is impact on children, impact on citizens, and I'd like to have your feedback.
Okay, so let's just resume the questions I'm going to be sending to everyone. Bonnie, I'm going to ask you to pick up on this issue about impact and how excellence and impact, and is that the link on society? Cornelius, you have the question about the extent to which the Commission is picking up on the broader aspects of prevention, not just prevention on patients, but actually looking at the cultural and societal norms within which decisions get made. Pierre, and perhaps also Valentina, you might like to answer this question, that there are new software tools coming forward that will actually help to rebalance out the diagnostic relationship between patients and doctors, so patients may be able to take on more of a leading role in the future. Right, I think those were the questions. And Professor Bismarck, about what do we do? Our education system produces highly specialised unidisciplinary people, and yet what we need is multidisciplinary research. Who would like to jump in first?
Well, following on the last one, that's the easiest to remember for all of us. So I think we are quite active in the EULAR now, what we call the School of Rheumatology, where we try to use the modern tools for communication. And in fact, you have, if you're thinking about one of the diseases, take osteoarthritis, you have different levels of knowledge. But the basic knowledge is for everybody the same. So you can build a module, so to say, for patients, for public people to learn about osteoarthritis. Then you can add another layer for the health professional, focusing on what exactly we can do without with what we call the non-pharmacological treatment modalities. And then you can add on that a module about early diagnosis, about sophisticated imaging, about sophisticated treatment. So I don't think we have different the content, only the level of it and how deep you go differs from person to person. And we have a system that is freely available for the basic part, and then the second part you have to register and to pay a little bit for it and things like that. So it's open to the people themselves to what level they go. So I don't think we are now really focusing on very detailed specialization. I think we start at the beginning, keep that open as possible. And of course, if you are interested in osteoarthritis, it can be at your level that you say, well, I want to need more, I want to know about specific MRIs, things like that, so you can find it. So let's try to have it open, and you're not aiming to make only specialists.
Okay, so within your own organisation, you're starting to provide some basic modules that anyone from a different discipline, a specialist nurse, somebody else could access to broaden their knowledge base, and that's freely available.
Part of it is freely available for the public level and the patients or the citizen level. If you go further, we have to ask some money to get into it.
Okay. Pierre and Valentina, let's pick up on this question about the fact that there are new tools coming that will equalise out the patient-clinician relationship.
Well, since I have the microphone, maybe I'll just start. I don't think anybody in this room can really predict the extent to which digital will impact everything we do, which of course will give rise to the platforms that have been alluded to in terms of interaction between stakeholders and so on. But also much more than that, looking at patient-reported outcomes, behaviors, biosensors, and of course on many, many thousands of people, and how's that data going to be managed and assembled and analyzed. So I think the digital piece, and it's reflected in the number of digital and informatics companies that are now very interested in joining us with the pharma sector and diagnostic companies and so on who are already involved in IMI and really want to drive some of these agendas, which is great. So I think it's really a space to watch, and I think the impact is going to be significant.
Thank you. Valentina, do you see great potential?
Yes, for sure I see great potential there, but it comes with additional challenges because this means also fragmentation of information. So this is all information that needs to be collected and analyzed. That's why maybe my comment is a bit biased, but I still see a role for patient organizations there to collect and channel the voice of patients, because it might be really difficult. Imagine already now, I guess it's very difficult when it comes to research. Healthcare professionals have data, have information, but it's not easy to collect it and bring it forward.
Okay, thank you. Bonnie, let me pick up again on this issue about, excellence and impact.
Yeah. So I will first start to answer your question because it's related to your question. So first of all, research of impact for policy measure, I think it's very interesting because I don't think there are a lot of policy scientists around who do that, but I think there is a trend in the future we will need more of that. If you discuss also with members of the parliament, risk assessment, for example, is something very important. It's linked to technology assessment, so impact of policy, I think, is an interesting field, which links me also to your question in the sense that excellent science nowadays has to more and more to prove its impact on value for society, but the question is, of course, how you measure that, and is also from discipline very different. So for Science Europe, we basically promote a broader notion in the sense that science in itself has a value for society which should not be questioned, and so that's the broader notion of impact of society, which also brings us to the point that any breakout through research needs a long-term evolution in 10 or 15 times, that you can't let's say made up breakthrough science within short-term policies.
Cornelius.
I think I can be short, especially on the last question. So yes to primary prevention, and sorry, so that was a misnomer. Impact is not only on patients but on citizens, very clearly, and I think that is part of our program. And also yes to implementation research. Yes, we need to bridge that gap and see how things can be better translated, but also just cautioning, there's at some point also a point where research ends and where implementation starts, and where policy makers and especially national health systems need to pick up. So it needs to come from both sides. But yes, and we have gotten into implementation research also more over the last years, particularly in the with the Global Alliance for Chronic Diseases, for the moment, particularly on vulnerable populations here and on low and middle income countries, but that is something that is on our radar, and you'll also see that in the 2018 to 2020 work program.
Thank you. Any further inputs? Yes, we have a question here. This is your last window before the end of the day, so take your opportunity to make a comment.
My name is Susie Magri. I come from Cyprus. It's a comment, actually, and I wanted to stress what Valentina said about the involvement of patients on all stages of research. And I think there is more to be done on that, because, yes, we can help on research, but we need to come in contact with the people doing the research, and we also need to be well informed of what is expected from us. So maybe the EPF can create a platform, or EULAR, that these two parts come together and we can get the best results out of this. Thank you.
So, panel, let me put a final challenge to you. If I could enclose this room in a bubble, and I had a magic time machine, and I could move us forward 5 years, so we would be at the end of the next mandate, and EULAR has convened everyone again in this room. The food is as good, the conversation and the company is as good. What are we going to be talking about? What do we hope we're discussing as having just achieved in the past 5 years? Tough question at the end of the day to tax our brains, but we've had recommendations about what should be in the next programme. So what do we hope it will have achieved? How will it have moved things forward? Professor?
So it's very difficult to predict the future, of course, but one of the hopes we have, and I think we clearly have some indication that it's realistic within the coming 5 years, is that we change the outcome of our clinical trials, because in the past, if you're looking at rheumatoid arthritis, we were very happy if we did not get a progression of the damage. And now we're looking at people, defining them early, find them very early, treat them very early, treat them very effective. So the outcome at that time would be for clinical trial a sustained remission without using drugs. So that's an example of something that's feasible within the coming 5 years. And excellent. I will be very happy to discuss the implications of that in 5 years' time.
Great. Pierre?
Well, since I'm representing a public-private partnership, I'll talk about one of the existing challenges, which is a cultural challenge with that interface. But with a disclaimer coming from one of the Nobel Prizes for Physiology or Medicine, Arthur Kornberg, said, the future is invented and not predicted. So with that disclaimer, but I seriously, I think we've come a long way in terms of how the pharmaceutical industry works now much more collaboratively than it did, and works across this public-private divide in a completely different way. And I think we've been able to create this quite special new ecosystem. Of course, it's at a even though I know people look at the IMI budget and say, wow, this is huge, but it's actually on a relatively small scale relative to what needs to be done. The first objective of IMI 1, the first phase of IMI, was be a public-private partnership. That was the first objective, because it was not at all obvious that we could actually create a positive interface between such divergent actors. But now, having achieved that, and in 5 years' time, I think we will have extended those interfaces to include these other sectors that are so important for the ultimate success in personalized medicine, in prevention, in whatever. Because we're seeing a convergence of technologies in this space. And we will need all of those technologies and those sectors on the platform. And that's going to be, I think, the success of that public-private partnership.
Excellent. Valentina?
So what I would see in 5 years.
What you hope to see.
What I hope to see, yeah. So ideally, of course, a system in place for meaningful patient involvement. I would even talk about something like a patient involvement mainstreaming, because patient involvement comes with also need for resources to make it sustainable. So when we talk about this, we have to take into account that there are resources needed to make it possible, patients that need to be educated, other stakeholders that also need to be educated in order to make patient involvement a reality. And I think that's enough. I mean, it's quite, it's quite challenging, so I will stop with this.
Okay. Bonnie?
Oh, my wishes are more humble. I think it would be great if there would be more spaces, labs, pilots, where you can experiment scientists with entrepreneurs, with citizens on solving global problems.
Cornelius?
I also try to stay realistic. I want as many as possible innovations from FP7 and from Horizon, and that means innovations means products, processes, successful implemented in health systems, and with a measurable impact on the quality of life of citizens and patients. And in particularly, I would like more really system-wide implementations of personalized medicine, at least in certain areas. I think we are close to it in some member states, in some circumstances with oncology. We're still far in many other areas, and I think, yeah.
Now that I've asked the panel for their wishes in 5 years, let me open it to you. Does anyone have a wish that they would like to see achieved in the next 5 years? It's not easy, is it? The task I set for the panel. Let me share with you, a few days ago I was facilitating a big conference looking at the future of Europe, and we had a session on the budget, and people were brainstorming about how the EU budget could be more relevant and more accessible. And one of the ideas was that €1 billion should be set aside for participatory budgeting, meaning the citizens could have a direct vote on what they thought the money should go on. And so that was one idea I might put forward for the panel to comment on. And secondly, different people made a pitch to the audience about where the EU budget should go. We had people there from the health sector, and they said, look, right now we have 2% of 17%. And we think health is so important, it should have more money. And at the end of our votes, people voted in the room that 9% of the EU budget should go towards health. And at the same time, we had a public debate on their online section, and more than 350 citizens from across Europe voted, and they also wanted to have 9% of the EU budget to go on health. So let me come back to the panel. If the citizens had more of a say, do you think they'd put more money and focus on health? And if so, what could we do with it? Cornelius, if your money was bigger, what could you do?
I think to answer your first question, I think from everything I know and hear, there is actually a good chance that citizens would allocate that to health, and probably also at least a part of that to research. And I do think that we still benefit from a relatively good reputation compared to other policy areas. And what will we do with it? I think we have no problems. I think I'll talk to my colleagues and they'll have great ideas, and we'll talk to the scientific communities. I think there's absolutely no shortage of good and impactful and meaningful ideas.
Anyone else? Pierre?
Well, I think they would vote for health, and I think I would put it all into prevention.
Okay.
What do you mean by that?
This lady articulated extremely well. I mean, I think that if we, because obviously from where I'm sitting, I'm very interested in innovating, in creating new diagnostics and medical interventions and so on and so forth. But health systems are not going to be able to sustainably implement those innovations unless we keep 90% of our population as healthy as we can.
Yep.
And that is all to do with nutrition and environment and and pollution and all of the things that you were mentioning.
Housing,
and so,
mental health.
And how we balance those things out, because to get prevention long term on the political agenda, as you know, is very challenging because it's a long term play. It's not a short term play. And so no politician is going to see an impact of putting billions of euro into preventive strategies in a few years.
In time for the next election cycle.
Exactly. So I think, and yet that is what needs to be done to keep our population, the citizen, healthy, with their own, of course, involvement, because they have if we need to change behavior, they are at the forefront of that behavior change. But also we have to create an environment that is a healthy environment so that when they do that behavioral change, it's impactful.
Thank you. Valentina or Bonnie, do you want to
I'm not surprised about the outcome of the survey. And it's because happiness is mainly linked to good health and to the idea that when you don't have good health, at least your situation is taken in charge in effective ways by the healthcare professional, by the government who will reimburse your treatments and so on. So it's not a surprise at all.
Bonnie.
I'm never surprised that citizens would put his or her health as a priority. I think there are other priorities, but so I agree with that.
Good. Okay. Well, I think I'm going to now bring this section to a close and say thank you very much to our panel members. We asked you the more traditional questions, and then we asked you, perhaps unfairly, to predict the future, but I think you rose to the channel. And thank you so much for your input.